Good day, and thank you for joining us for this discussion, Health Equity, Will Virtual Care Close the Gap? I'm Andre Picard. I'm the health columnist with the Globe and Mail, and I'll be the host and moderator today. After more than a year of this, we're all pretty good at this online stuff, but if there are glitches, please send an email to marketing@globeandmail.com and they'll take care of that as quickly as possible. That email also appears on the webcast slides if you've forgotten it. I'd also like to encourage you to comment and ask questions for today's speakers. You can do that by clicking on the Ask button, that's ASK in case I mispronounced, at the bottom of your webcast console, and I'll make every effort to weave those questions into the conversation as we go along. Now, COVID-19 has shone a spotlight on many of the shortcomings of social and political policies in this country, and nowhere more so than in healthcare. One of the most important lessons we've learned during the pandemic is there's a lot of inequality in society. We know that certain groups have been hit disproportionately by the pandemic, elders, essential workers, many of whom are racialized, for example. And even though we have universal healthcare in Canada, access to care can also be inequitable for a host of reasons. Now, another more positive lesson of COVID-19 is that virtual care works. Patients like it, and so do providers. The Globe and Mail has been staging a series of events about the future of virtual healthcare. So today we're going to combine these two important topics, health equity and virtual care. We're going to try and explore how the shift to online medicine will or should make care more accessible, or maybe it'll make it less accessible. Maybe it'll just be different. We're going to discuss this with all our expert panelists, and I want to get right to them because we have an excellent group, so I want to introduce them. First, we have Karen Adams. She's the Chief Information Officer and Global Head of Enterprise Solutions at CloudMD, which is a health technology company. Karen has spent the majority of her career as an advocate for mental health and focuses on accessibility of care. Welcome, Karen. Maybe give us a wave, say hi. Great, thanks for being there. Next, we have Dr. Thomas Unger. He's the psychiatrist in chief with St. Michael's Hospital and Unity Health. He's in downtown Toronto. He's a family physician, addiction medicine provider, and a psychiatrist. Welcome, Tom.
Thank you.
Great, I didn't even have to tell him to wave. He's used to this stuff. We also have Jace Watford. He's a patient advocate and peer mentor. For 6 years, Jace has worked on the front lines of mental health, and his own personal journey includes living with mental illness, homelessness, and substance abuse disorder. Thanks for joining us, Jace, to add that really important patient perspective. And the peace sign is even better than a wave, so thanks for that one. Great. And last but not least, we have Dr. Simmerpreet Santanwalia. She's the co-founder of the South Asian COVID Task Force. She practices emergency medicine, and during COVID, she's been very busy. She's co-founded an organization to connect patients with their families virtually, and another focused on multi-language outreach. Welcome to us today, Sim. Thanks for joining us. And I want to first, before we get started, I want you to tell us a bit about your shirt. This is our shot. Can you tell us a little bit about that campaign?
Yes. So This Is Our Shot is a campaign that was launched just a few weeks ago to encourage people to go out and get vaccinated. We still know that there are a lot of people that are hesitant and on the fence. So This Is Our Shot is a campaign that is available in 27 different languages and growing, where we have frequently answered questions. We also have a town hall later today, and the shirts themselves are available in all these different languages. So this one says, "Get your tika," and tika means to get your vaccine, in Hindi, Urdu, and Punjabi.
Wonderful, thanks. A good way. There is some inequity in vaccination, so we might get to that in passing. But thanks for telling us about that, because I know everyone's going to be curious. So I want to get started with the conversation with a big picture question. You know, we've had this massive uptake of virtual care during the pandemic. I've heard it said many times that we've made 10 years of progress in 10 months. So I want to start by asking, is this a good thing? And I think I'll start with you, Tom, to give us this big picture. Is it good that we've embraced virtual care?
It has been a big surprise at how helpful it's been. It's really been an enabler of care. And thank goodness we had it available at this time, as opposed to maybe 30 years ago when you couldn't do this. So we've actually been able to stay connected or do innovative new ways of enabling care, virtually using your phone, or smartphone, using your tablet device, and a variety of other ways where we could do it. And the healthcare providers have embraced it rapidly, and it's been better than I think most of us expected. So the virtual care has been really helping save us as an enabler to maintain care, continue care, provide care that we've been fortunate to have. It's not perfect. We're doing in-person care, of course, when needed, but it's really been a lifesaver to the provision of care throughout this time.
Great. So we heard this good, nice big picture. Sim, is there a downside of this, or some people getting forgotten in this sea change we're seeing?
Yeah, so what we found is that, especially from the emergency department, what we often hear is that people have tried to sort of, they're afraid. They're afraid to come to the emergency department first because they're afraid to get sick. So even with having the virtual care available, some people are very hesitant. And one could be that they don't have the technology. And the other one is very much that it's digital literacy. A lot of people don't have that sort of means or literacy when it comes to digital connections. And so we often hear that, when people are like, we're like, oh, have you spoken to your family physician? Like, oh, my family physician's not open. It hasn't been open for a while. And I was like, well, do they provide virtual care? Yes, they do. But people don't consider that as an option. So I think that with regards to sort of a lot of physicians and specialists embracing it, yes, it has helped to sort of see people quicker, especially when we have these populations that are afraid to go and seek care. However, we are missing out on some people in the population who just need that extra support to get there and to use this sort of technology.
Right. And we'll drill down into that over the time that we have today to talk about how we can fix that and address some of those issues. Now, Jace, from a patient perspective, we heard Sim say some people are scared. Are you scared? Have you used this technology at all?
I definitely, I have used the technology. I think though, I think I'm not convinced that virtual and digital care presently is meeting a client where they're at. I mean, physically, sure, like literally you're meeting me in my living room right now, but are you really meeting me where I'm at? As far as overcoming barriers, virtual care is kind of a triage tool, I find. And that we're forcing individuals to meet the service providers where they're at. It's not necessarily a holistic measure. It could use for some upstreaming modifications in the form of like better capacity building. But for me though, specifically because I'm in the North and there's a lot of individuals here who are classified as lower socioeconomic status, we kind of have to stop othering them. We got to start seeing the whole person, recognize the other, grant them human agency. There's a lot of intersectionality here. So regarding any kind of a change, I don't know, yeah, I think there just needs to be a little more, I think we embraced virtual care because it was kind of the only option available to us at the time. So I'm concerned that this is going to be the primary vehicle going forward.
Okay, and we'll get into that. How do we use it appropriately? And maybe Karen, you can help us with that. Is that the key? Is it getting the right care at the right place in the right way at the right time? How do we do that? Get the right mix of virtual and in person?
Yeah, thanks for that. I think really important, the conversation we just had, which is meeting the person where they are. COVID has really directed us into being enlightened around virtual care. Maybe people tried it who never would have tried it before because it was the only option that was available to them. But for the longevity of healthcare, I really think it's starting with the end user and where they need to initiate. Start with the patient. And it may be a mobile app, it may be a web app, but it also may be just the old-fashioned telephone where we need to connect with the person. So I think that's really important. I think I liked the concept. I think, virtual care is about assessment and triage and navigation. And I think, one of the things we've been really focused on is taking the square roots of primary care, virtualizing them, connecting them. But then it's all about how do you become navigating in the health system to remove barriers, to get that coaching, to get that connectivity, to know that you're actually doing the right thing, right?
And Tom, to address Jace's point, you do mental health counseling, psychiatry. How do you ensure that you do meet the person where they are, that you make sure that it's right to do it online and sometimes it's not? How do you figure that out?
Yeah, that's a big issue because sometimes you don't know till you start up when you're in the interaction and then it's a surprise to you. So ideally, which we don't quite have, or we have a patchwork of, is a air traffic control office analogy of an intake office that can kind of triage, screen, and then direct people to the right place. We don't really have very much of that. We have little bits and bobs of it here and there. Often we think we're in a routine appointment and something surprises us, and then we have to switch, and we have to ensure in-person care, direct them to an emergency room, have them come in, or plan to book them for in-person assessments, which we continue to do. In our emergency room, our inpatient unit, and some in-person care has continued throughout the pandemic, regardless of everyone's fear. It takes encouragement, but we're often surprised by that. So that's the enablers and the people and the thinking around the technology. The technology is just one part of it, but you need people and a whole service design around it to kind of direct that. And that's something that maybe people haven't thought through so well, because you will get surprised. I've had to face emergency situations where someone is suddenly acutely suicidal and going to act, and have to, do whatever we need to do to ensure safety at that moment. And that occasionally happens. And we plan for what we can, and then we get surprised.
Wow. But are there upsides, like you actually get to see the person's home, et cetera, that things you wouldn't get in the office?
Absolutely. It's kind of a little bit, I heard David Goldblum mention this before, a bit of like a home visit used to be. You get a bit of set of their context of how they're living. You can read body language, not quite as well as in person, but pretty darn well. You see the home. You might even see the family member go by the background. You have to watch out. We need some boundaries on it, because you don't want to see things you don't want to see. But it's actually a really interesting, different type of care. And we knew it was a bit available, but it wasn't really embraced. And that's turning on the switch to really having to use it more. That's been really interesting and helpful to us.
Now, Sim, you work in an emergency room in Hamilton. Some people might say, well, how can you do emergency medicine in online? Isn't that all people bleeding and dying? How do you do ER stuff online?
So we do have urgent care that's available virtually, and it actually is good, because in the sense that people can actually, who have the ability to access it, can be triaged to find out whether or not they need to come to the emergency room, or is it something that they can just follow up with their family physician. Now, with that triage model, there also is the ability to sort of order the tests and imaging that is required. And so by the time they get to the emergency room, that sort of all that sort of testing and imaging has already been sort of organized for the patient. However, again, this is the people that can actually use it and are like savvy with the technology. And so that's the one thing that we have to always keep in mind, is that, are we missing out on the people who are sitting at home that don't have the ability to connect virtually, and also are afraid to come in to the hospital or seek medical care in any other way? Because there is a lot of trust with family physicians that we know. And since the start of the pandemic, there has been this sort of change to virtual care. And like I mentioned before, people don't consider virtual care as an actual visit for a lot of people out there, especially our elderly population.
But for you, I'll ask the same thing I asked Tom. Is there an upside? Is there things that you didn't get to do before that virtual care allows you to do?
So I think virtual care allows us to connect with patients that are quite far away. So even today, with regards to sort of an email that I just received, is that we do have something that provides sort of virtual care overseas, and that's not something that we would be able to do before. So Canadian Doctors for India are providing medical sort of advice via virtual care in a third world country that is ravaged by COVID-19. So I think there is the upside with regards to reaching people who are in sort of those distant areas, like northern areas, etc.
Right. And Jace, you mentioned you're in Northern Ontario, you're in Thunder Bay. How do you deal with people with, you work with people who live in homelessness, for example. How do you make sure they can have virtual visits? Do you have to lend them an iPad? Do they come somewhere? How does that work practically?
Well, I mean, virtual care is quite useful, but it took such a long time to roll out to become to the version that we see now. There wasn't a plan for an event like this, so it took like 6 months to coordinate a plan. And social service agencies have long been silos, and collaboration and communication hasn't always been the greatest. So I mean, that period of time with individuals like previously, like myself and like the people that I work with, we're hard to reach. We're kind of on the fringe. There's a distrust in the system. Like Sim was saying, like I've done so much wound care because a person's arm's going to go gangrenous from just like cuts and sores, but they refuse to go in and get help. So there's already distrust. There's a digital literacy that's a huge issue. A lot of individuals would just rather not. You know, like with that time period was so crucial because it felt like we got left on our own. So suicides went up, relapsing went up. I think even there was a report that came out this morning from the ODPRN. Overdoses since the pandemic started, 79.2% increase. So like the people that were hard to reach are even harder to reach. So it's difficult to reach them. And then it's even more difficult to try and teach them how to use the technology. Because in a level of priority, you can't address your psychological needs before your basic needs are met. So if we're not taking care of that sort of stuff first, it's kind of putting the cart in front of the horse. So there's some serious issues there in regards to reaching them is tough.
And I'll just mention to the audience, whenever there's jargon, ODPRN is the Overdose Prevention Research Network. So just so people in the audience know what that is, and they should look up, there's a good story in the Globe about that report this morning. But I want to ask you, Jason, you mentioned the distrust, but imagine that cuts both ways, right? Like a lot of people who live in homelessness don't like to go to the ER because they get judged. Can they have a little bit more freedom if they're on an iPad, for example?
It could be, but the thing is, there's something to be said about the process of going to think of it in regards to like a safe space. So if I'm a vulnerable or marginalized individual and I'm talking to an abuse counselor, and I am in lockdown and I'm in my home with my abuser, it's difficult to talk about these things with. Like it's just there's not a safe space. Even myself, you know, like I'm in an apartment that has thin walls and I've got very nosy neighbors. So when I'm online talking to anybody, I'm not disclosing fully 100% because I don't feel safe. I'm very vulnerable. So when you're living in precarious environments, you need to have a safe space to go, and that's what the doctor's offices present to a lot of us, where it's like we don't really want to go, but we will go anyway. So if I've got a meeting here at home, I'll miss it or whatever else. I know the with a lot of the local frontline agencies here in Thunder Bay, a lot more meetings are being missed, and it really takes a lot less physical strength to actually just turn on a laptop. But there's more meetings being missed.
Okay. Now, Karen, we've talked a bit about homelessness, the language, mental health. What about the elder population? We have this assumption that, well, old people can't use technology. Is that true?
Yeah, I don't think that's necessarily true in all cases. Of course, in some cases, they might not be as quick as some of the other ones, but you know, technology really has started to gravitate to people do FaceTime with their grandchildren, people do. So it's about a comfortability thing. But I think the really important thing about the virtual care is, you know, it's really about engagement. It's really about assessment, engagement. It's about understanding where a person is today, where they want to go to. And I think one of the things that we've been very successful on is starting to match a navigator, a nurse case navigator who becomes the trusted person and just a great example with the elder, right? Somebody who they can talk to, they can explain their entire situation. And then you start to navigate and coordinate the care of the whole person. And you build a profile of the individual where their profile is personalized. You can nudge them, you can check in with them, and it starts to build that trusted relationship that people need. And oftentimes for the elderly, for whatever the profiling we want to use, part of the challenge is just making sure that we understand the spectrum. And at times, especially with mental health, today could be a good day and tomorrow could be a really bad day, right? And the next day could be a good day. So it's not this continuity of care idea and being able to reach out when you need to reach out and get that support. And looking at the mental and physical health of an individual. That's what's missing in our healthcare system today, is the lack of connected care and the ability to truly look at how do we ensure that everything is working together and that the person feels in control and empowered to do something about their health. And I think that's really where we've come to with virtual care, is that if it's 9 o'clock at night and I want to get on my iPad and talk to a counselor, or it's 7 o'clock in the morning, I'm not confined by the office hours of a particular person, and I have to go to the provider's hours as opposed to my hours, which I think is important.
But I want to come back to that word you used, empowering. So is this virtual care, is it empowering or is it disempowering, or is it a mix of the two?
It's a journey. It's a journey. So what I would say is, how do you get to empowerment? Here's how you get to empowerment. You engage somebody, you educate them, you do these assessments, you triage them, you have conversation with them, and then you're checking in with them. And so I might see my mental health provider, and then I might be over here seeing a chronic pain specialist. And this navigator becomes the person who's connecting everybody, building your personal profiles. And it's really funny because the concept of a personal trainer for physical health is not uncommon to many people, right? I know people in their late 70s who have a personal trainer who's keeping them healthy. So what is so odd about bringing that coach or that navigator to our health and having them as our trusted resource to connect us to all this disparate information, especially with the elderly? My mom comes home after a doctor's appointment. She can't remember what he said while she was talking to him, but the ability to have these online profiles where I can go in and look at her results and talk to her about her results. And so we've taken this and we've taken this highway. So think of it like a highway. You come on a highway, we navigate you to your off ramps, you get connected to all the programs, we bring you back, but all your data, all your information you own and is on this highway that you can access. It's very, very powerful. And that's what creates engagement, because I own it, I understand it, it starts with me. It doesn't start with the service provider, it starts with me, which is really, I think, a differentiator in how we start to think about healthcare.
Yeah, we certainly don't make good enough use of navigators in healthcare. We use them in cancer care, but not many other places, unfortunately.
Well, just a point on that, because I think you're really, if we take the cancer approach to navigation, that's what we've built in our program, where it doesn't matter if it's mental health, physical health, I need to connect to a specialist, what's the wait times, how does the public system work? We've brought that to healthcare, and people are feeling so cared for because there's somebody that they can just reach out to on their time, phone, however, and get the information they need.
Okay. Now, Sim, let's talk about some practical solutions to that. And you've done some real practical on the ground work to deal with inequity in virtual care. Talk to about one of your, I know you have a few programs, talk to us about one of them, how it works.
So in the emergency department, I do work in Hamilton. So we do have a large sort of marginalized population that comes in. Now, say for example, during the COVID era, that we have someone that's been swabbed for COVID and is awaiting their results. The results don't come back for like 24, 36 hours. And during the beginning of the pandemic, it was actually 3 days. Now, with a lot of the community, what we found was that we had a large homeless population that was coming in, and they were unable to sort of have that access to check their results online or have someone call them. So what I did then was that I had adopted a program that has been done in St. Mike's before. It's called the Phone Connect program, in which I took donated phones and with the help of Bell Mobility and their SIM cards, provided those to our social workers to give to individuals in order for them to have access to these hospital to home sort of programs, having their results that could be sort of called to them. In addition to sort of having access to community care such as addiction services. And what we found afterwards when we called some of these individuals is that they used the phones not only to access these programs, but also to connect to family members who they had been estranged from for so long. And especially in this sort of isolated sort of pandemic times, we found that it was really beneficial. Now, the other thing was that during COVID, we also had stringent, and we still do, visiting policies in hospitals. Often case, we were calling patients' families just as they were prior to get intubated to tell them about what was going on without having them at the bedside. And that was so disheartening to have this, where people would be like, can you please tell my family member that I love them? And then we started using our own phones to connect people by FaceTime and Zoom, etc. We then sort of started this program called Frontline Connect, in which we again took donated devices, provided them to hospices, long-term care facilities, retirement homes, and also worked with foundations at the hospital to have iPads available so people could connect with their family members. And you would just see how people's faces would just light up when they could see their family. And we honestly, before the pandemic, I don't think we really appreciated how important it was to have families there at the bedside. It is so vitally important. And to virtually bring them to the bedside was something that was amazing that we could do.
Yeah, there's been some touching stories about those interventions and the great programs that you've launched. We'll see if we can put some information in the chat for people on how to help you out if you need some more donations of phones and such. Now, Tom, at St. Mike's, St. Mike's is well known for having a real downtown urban population, a lot of marginalized clients. When you made this shift during COVID, how did you make sure they were not forgotten? What were the practical things that were done?
Yeah, so one of the practical things was our healthcare providers at St. Mike's Unity Health are tremendous people, as most healthcare providers are, and they were really doing workarounds to cover those gaps in the system that didn't exist, whether it was a charity, private organization, or the individual providers were finding solutions quickly. We had workers go out in the community to the shelters, to find persons without housing, to our severe mental illness clients and other clients and elderly with dementia, to bring them a phone, to bring them iPad, to physically help them connect to that appointment. Because one thing to give the phone, if you don't have the cognitive capacity to connect, I'm terrible with technology myself. I need help at home. I can't imagine if you have that type of a disorder who can push the buttons, and if you lose connectivity, just to sit there with them and support them and help that enable that care, in addition to the technology, the people. In the hospital, we had challenges sometimes. We wanted to keep some of our physicians safe because we were having so many doctors go off under investigation for COVID symptoms. We couldn't staff our wards. So we actually had some of our medical staff working from home with iPads to patients in the office and some of the doctors in the hospital, so that we kept sort of a safer, we called them a clean population, in case others had to go off work. So we did whatever innovative things the individual providers could do to overcome the gaps in care. Throughout the emergency room, started a shelter. We had tremendous donation from our Unity Health St. Mike's donors to get money for clothing, phones, iPads, connectivity, whatever it really took, so that it was available to them. So it was really quite beautiful to watch. The challenge was, it's a shame that the individual providers, private industry, or charities had to overcome the cracks in the system, which became gaping craters.
What was the biggest crack? What was the hardest one to deal with?
Well, the simplest thing, like, you're under investigation, go home and we'll call you with your results. Well, they had no home to go to. They had no telephone to call them with. And when we called public health, perhaps, to try to get housing, they weren't there yet to do that. They hadn't secured the housing. So we ended up starting, to the credit of the organization, they created a shelter in the emergency room in the hospital, but that's not where you want it. So all the wraparound form follows function things you need to do to provide care. We had the providers were outstanding, but the system as a whole was very patchy, and it's connections in between that got exposed and we got noticed. Amazingly, they came to the rescue really quickly, but it's a shame that the system, the individuals did that. Now we're finding how to sustain those, but it really wasn't there in the first place.
And Jace, I want to ask you the same thing. What were the big cracks? What were the hardest things to deal with for you practically on the ground?
Well, yeah, that's I think what Thomas said in regards to the patchiness. If you look at it, it's almost as if our system is based on a utilitarian model. So the needs of the many outweigh the few. But I fall into that few kind of bracket, right? So if you apply, let's say, virtual care, whatever you choose, in a utilitarian model to the marginalized and vulnerable peoples, there's just huge gaps that people continue to fall through. It's from a lived experience perspective, a lot of us who are on the lower socioeconomic status level, or who have mental health or whatever, we're used to being abandoned. And that abandonment is scary, it's triggering, it's re-traumatizing. So when the pandemic started and everything kind of got cut off like that, or like it just slowed to go and the gaps got bigger, it sunk us in a deeper hole, and then our isolation became more isolation, right? So now we're no longer thriving, we're just trying to survive.
Yeah. And any practical things that you did that you can share with the audience that really helped your population, take advantage of virtual health?
I mean, if anything, I honestly, because if we're a very resilient bunch, we're used to having hard times. So it galvanized us to a certain extent. Those of us that could created more online Zoom meetings, so let's say Narcotics Anonymous and Alcoholics Anonymous, more frequency for meetings. So let's say my city has, we've got one meeting of each per day, and that goes 7 days a week. But now, because you're connected to the internet, you've got more meetings happening with more frequency. So and you're also enhancing your worldview on addiction, because now you're meeting people from, let's say, India, from China, from England, whatever. Because because the only requirement for those groups is the desire to stop drinking or stop using. So then you're opening yourself to this wonderful new array of help and support.
Right. Now, Karen, we have some good audience questions. I want to, as I said, where you weave them into the conversation, I want to throw one your way. Someone's asking, is there actual research that shows that virtual care improves care, or is this just all wishful thinking? Is it just because it improves care for the people who already are, have advantages? Is there actual research to back this up, what we're doing?
Yeah, so there is research to back it up, and I think it depends on, what portion of the healthcare. There's research for mental health that would say that it reduces the stigma, that it gives access to care, people are more comfortable. There would also give credence to the fact that people in the virtual care market can get access to a variety of different providers, and we can actually match. So matching is a huge part of the whole virtual care process, because comfortability is important, culture, gender, experience. But the other piece that I think is important on virtual care is we have to remember that virtual care isn't for everyone. So virtual care is a way of engaging people into a process. So I would say the research for virtual care is all over the map, but there is research to totally say it gets people engaged, increases their comfort level. But the only other thing I think that would be important as we talk about research and design around virtual care is that we have to be careful to understand that virtual care was born out of a lack of connectivity. And I think the thing that's important to recognize is that where virtual care and the research will take us is that when we're able to look at, this is where I think we're really going to see health outcomes. Health outcomes is the research we're looking for. So once we're able to monitor a person from the point of intake straight through to all the connected care, and how, we know in our business, connecting people to the right provider can save 225 disability days. That's a very impressive number, both from a financial perspective, but more importantly, from a care perspective for the individual. That's 225 days less that they have to be incapacitated or on disability. So I think the research is varied. I think we are going to see more research as we manage, monitor, and look at the health outcomes, and the satisfaction of the patient is going to be equally important. We're seeing huge satisfaction rates. The last thing I'll say on the virtual care and the research is we have to be very careful we understand what we're measuring. So there's the public system, which is the general practitioners. And then there's the private system, which unfortunately a lot of the mental health is falling on the private system for psychotherapy and people to pay for it so that they can get better. And I think an effective virtual care system connects the public system and the private system. So we don't need people paying for healthcare that's available publicly. We just need to know where those people are and who can be connected virtually and who can't. And then we'll start to be able to truly understand the research of the impact on people.
And Sim, I want to continue on that theme with you. We know a lot of this virtual care is actually private. There's the Maples of the world, these big private companies. Do you worry that's creating a bigger gap, that some people just can't afford this, so they're not getting those advantages?
Yes, absolutely. I think that's what we have to make sure that when we have virtual care sort of implemented, that it does sort of target the people who we are afraid that won't be able to access it. So that's where we come to accessibility and equity, which is so important. So the supports that Karen's talked about before with the navigators, 100% we need that. We have our early adopters. Those are the people who are digitally literate. They like virtual care. They like sitting in their home, and they like sort of not having to go anywhere in order to get to a physician's appointment, et cetera, whatever sort of service they are trying to get. However, the people that we need to focus on are these late adopters, okay? So these are the people who are not only probably more of the elderly population, a lot of the marginalized and vulnerable population, and a lot of people who don't speak English. So that's a big thing, right? Because language is so very important. We've seen this everywhere when it came to getting COVID testing, to getting signing up for vaccines. If you don't speak the language, people are not going to understand. And knowledge is power, and that's how we empower people as well. So I think that with regards to the supports when it comes to virtual care, that is something that we 100% need to focus on, is how can we help the late adopters and the people that do need all those extra supports in order to access the virtual care. So even having sort of that model, which there is sort of that private model, but you do need to have that public model. So people have that sort of accessibility and don't have the means to pay for private care.
Let's continue on the language part, because we have a good question from the audience about this, saying, can't virtual care help overcome some of these language issues? Say you live in Lethbridge and you speak Urdu and there's no doctor locally. You can talk to someone in Hamilton or wherever, anywhere in the world. Is that a benefit? Can this overcome the language issue, especially in a multicultural country like Canada?
Yes, I think that is a very big positive, in that you can access specialists, et cetera, that do speak certain languages. However, in order to get to that point, you have to be digitally literate in order to access that. But yes, that is a very good point.
And Tom, I'm going to throw another audience. The audience has better questions than me, so I'm going to steal all of theirs. Someone's asking, who decides what platform is appropriate? If it's phone or online? Is it the hospital? Is it the individual practitioner? Is it the province? Is it based on billing codes? Who decides this?
And then there you have the patchwork of healthcare, because it's any and all of those, depending on the person, the place you're working at, the province you're in. I like, when possible, to be able to see the person as well with virtual care. It gives me information. Some people don't want to, so it's often a negotiation and discussion within. If I could pick up on one thing, though, that Jace said about isolation of some of the people, I'm just going to go to the mental health thing for a section, because the equity includes, socioeconomic, social determinants of health, money for the device, and that's one part. But there's an equity issue that I see. I work with the Mental Health Commission of Canada on their structural stigma research team, which is a structural inequity, because mental health, maybe like physical health, it's not only the technology, you have to have the providers available to deliver that care. So who they phone, where that intake, who books them, there isn't an equitable allocation between physical and mental health to even navigate that for you, organize the very question you asked. It's kind of a segregation model. I know that's a bad word, but mental health is segregated from the rest of care in all kinds of ways, from how it's booked to how we count the visits to who the providers are. And because it doesn't even show up on a quality dashboard under the equity pillar, because we have one of those, it's not noticed. We have to get it out there, and then we can go to the equity, and technology is an amazing enabler of care, but they don't even know to allocate the resources to the technology in every department. I mean, we do have it here. We have cameras and everything, but the bodies and the human power behind it that enables it is what's not even noticed.
And I see both Karen and Jace want to jump in on that. They're nodding vigorously. So Jace, what were you thinking when Tom was talking there?
One fantastic point. But I mean, like in regards to the equity and the just in a level of just finances, right? So like if I can't pay rent or put food on my table, then I'm not going to be able to be focused on virtual meetings. So food costs have risen, cost of living has risen. So like if you're providing me a device, that's all good and whatnot, but I know people who have sold their devices to be able to pay food to buy food to put on the table for their kids. Like the disparity is monstrous. What it was determined that the average person would get $2,000. That's what it took them to live. Ontario Works is $733 for a person to live. That disparity is a monster. So giving somebody technology when you can't even make ends meet, that's difficult. So I just wanted to tack that on top of what Thomas said. What Thomas said is absolutely fantastic, and I hope that there's something to be done there.
And Karen?
Yeah, so just wanted to just further talk about a little bit the physical and mental health. So often we see that people will present with their physical ailments. Very easy to describe my physical ailments, very common. And what's really underlying it is a mental health issue. So I think that coordinated care, and that's where we come at it, that it's very important we assess for both the physical and mental health, because you will never solve a person's issue if you're not doing both. I think the second piece on the mental health is it's very important, yes, to have an assessment. So often people are struggling with mental health and we don't have an assessment. We don't actually know what is the treatment plan of the individual. So starting with the assessment and the navigation is important. And the last piece that he said that I think we need to really think about is whether we're dealing with a physical or mental health issue, the framework of understanding somebody's material circumstances. So it could be, what's the condition of their workplace? What's the type of home they live in? What is their economic status? Then looking at their psychosocial factors. So what is my social connectedness? Am I isolated? Do I have a network to help me? Do I have a support system? Then biological factors. Who are my parents? What are my genetics? And the last two are the health behaviors. So do I have substance abuse? Do I have lack of physical activity? Am I not well nutritioned? Am I not eating properly? And then what we're talking about today, which is the healthcare system and access and quality of care. Unless we're looking at all those dimensions, we will never get to outcome. And unfortunately, when we present ourselves to a care provider, we're usually only presenting one dimension. So it is very hard to look at the whole person and get them connected and really truly see that progressive measurement of somebody getting better.
Okay. And Sim, another question, I think I'll throw it your way. You can give it a try. Someone's asking, what about asynchronous care? Like, can you provide medical help by text, by email, WhatsApp, chat? Are there other things other than just the phone and Zoom?
So I think that yes, you can do that. So we have something like a model like that with telemedicine, with telehealth. So we know that a lot of people prior to going to the emergency department, they will pick up the phone and call telehealth. However, in the emergency department on the other side, we find that everyone that's called telehealth is told to come to the emergency department. So from both sides, like, I think that if someone is sort of underestimating what's going on with them physically or mentally, that is a good option in which they can get encouragement in order to go and seek medical help. So I think that having a mosaic of the two is something that could play well. Now, with regards to sort of WhatsApp, so just with regards to what we've done with COVID is that we know that a lot of misinformation, especially around vaccines, has been sort of, especially in the South Asian community, has been sort of disseminated via WhatsApp. So WhatsApp is something that is used by a lot of people in order to sort of share medical information, naturopathic information, which is probably not always correct. But I think that if you can tap into that with regards to having evidence-based information going out and being disseminated throughout the communities, I think it is very beneficial because it's so easy to forward something, much easier than picking up the phone and trying to get a hold of your physician. So yes, I think there is a role for many different sort of aspects of both using phone, email, and WhatsApp and other social media platforms.
But the thing you alluded to, is that a dark side of this, that everybody can turn to Dr. Google, whether Dr. Google is right or not, or there's lots of misinformation? Is that the downside of the virtual world?
Yes, and I think that's just with the onset of having internet. It's not particularly just virtual care. It's the wrong diagnosis, WebMD, where people try to sort of find their medical knowledge by Googling it. And so when they compare our 13 plus years of medical training to a Google search, it's actually quite disheartening because people don't understand there is a lot of information out there that is not evidence-based.
Yeah, it is a challenge. Jason, I want to come back to something you alluded to in passing, and that's the privacy issue. You know, a lot of people, especially if they're in marginalized conditions, they don't have the best housing. They may have a lot of people around. It's hard to have a, you know, a private conversation at the best of times. How do you juggle that practically?
Well, I mean, it's distanced in-person meetings. So like I'm in a northern community, and I'm in a northern community, which is the predominantly, I don't know if it's predominantly, but there's a high, there's a lot of First Nations individuals up here, and a lot of there's a lot of the things that they do are land teachings, things that don't really equate over Zoom. So like I find that a lot of our workers here are trying to connect with the community and individuals in the community. A lot of a distance meeting is happening far more frequently than Zoom stuff, because just there's some things that just don't translate very well. The privacy issue is it's big, and at presently I don't know anything that's being done to circumvent that. Like ideally, maybe, you know, you build an office, like a CMHA office or something like that. It's got 8 separate rooms. They each have a laptop. There's a tech support / work support kind of person on there, and people go in to do their one-on-ones with the doctors there. I think that might be the best idea, but right now I haven't seen anything that can overcome the privacy issue.
Now, Tom, we have lots of questions about privacy, so I'm going to ask you that one too. How do you deal with that if there's a spouse or a parent hovering? How do you ensure that people can be open with you, especially with mental health issues?
Yeah, that's a big, I mean, we have 2 aspects of that. One is the, you know, in the person's own home, setting boundaries and limits that you're private. And sometimes they can't, and they can't even tell you that they can't. So you have to really have your radar up for that one. I've had quite a few people, I've had interactions where they go out into the car if they have a car, and they've taken the appointment from the car because they don't want to be in the house, or they go for a walk, or in their workplace and they go in a closet, literally in a closet, when they have to be at work because they haven't been able to work from home. So privacy is a huge thing, setting boundaries and limits. And the boundaries can be for their privacy. The boundaries can be for my privacy because of, you know, they may be lying in bed and I say, could you please sit up, or please cover yourself with the blanket? So there can be all kinds of surprises with that we didn't have before with virtual care. The other privacy thing is, you know, we are for good reason, very careful about medical confidentiality and your health confidentiality. So there are only certain approved platforms through the hospital or through our healthcare systems that we stick to. And we purposely try not to communicate on other methods because they're not secure. So we take that very seriously.
And Karen, I wanted you to build, because there's so many privacy questions, or continue on this one a bit. What can we do to ensure that everybody has privacy, that it's not just the elite who have this privilege?
Yeah, so privacy, I mean, privacy is a huge concern around medical in and of itself. I think that part of what we were just talking about that's important is both ensuring that the person has privacy to share, but also the privacy of the platform. I liked what Dr. Unger said, is that, you know, we take that very seriously, and you have to make sure that you have all the right privacy protocols, that they've been reviewed by that there is a privacy officer where a complaint can go to, where you can, you know, share your upset around, or your concerns or your questions. Privacy officers are really important. And I think, you know, making sure that people understand when they engage in a service, where their consents are, how their information is going to be used, and ensuring that they own their information, that they know how to get the access to their information, and that it is their information. And there's a lot of education we have to do when people engage in the platform, because especially with the virtual platform, people aren't sure, where is my information going? Is this going to the United States? Is it staying in Canada? Who has access to it? Can my employer get it? So all of those, we spend a lot of time educating and informing people on their privacy and how they can actually access their information.
And of course, your privacy, your facts could fall behind the fax machine too. There's all kinds of privacy issues we have existing now in our low-tech system. So it's not,
Yes.
there are issues now. Sim, another question I think I'll throw your way. Someone's mentioning, you know, we've talked a lot about patients' capacity to use technology. What about doctors? What about the doctors who refuse or they're terrible at Zoom? What do we do about them? How do we ensure that they get up to speed too?
So I think once again, so when we were talking about sort of like the late adopters and the people that is patient side, sort of that need support in order to use the technology, I think we'd have to do the same thing with regards to our physicians in order to provide them with that sort of support and knowledge in comfort. That's the thing, right? It's the comfort, because people have, there's a lot of physicians out there that just want face-to-face sort of appointments and contact with their patients. But I think that increasing the comfort level amongst physicians by providing them with that sort of, education and having sort of navigators as well for physicians, I think that will help get that sort of people on board for that.
We only have a few minutes left, and I always I try to end panels on a hopeful note, or at least on a thoughtful note. So I want to ask each of you before we close to, come back to our basic question, our theme today, health equity and virtual care. Can virtual care close the gap? So I want to give you each an opportunity to say, what gives you hope that yes, this can close the gap, and where should we put our priorities? So maybe Jace, maybe you should kick us off. What do we have to do to make sure this gap does get closed and that the virtual care helps us do it?
Well, I think kind of summing everything up, my hope would be, I think surrounding counseling specifically, because therapy is a privilege, and especially therapy, like you pay to see someone consistently, but anyone that is on ODSP or not unable to do it, there's time limited sessions, so you can only see somebody 4 to 8 times. I would love to see if virtual care came into play, that those time limitations are removed, so you can see somebody until your issue is resolved, as opposed to kind of triage, stick a band-aid on it, give you a lollipop and put you back out there. So I would love to see virtual care go in that direction, because I think whatever limitations there are, people would be willing to ignore that just to see somebody continuously.
So your main message is consistency and access is really key for everyone.
Totally, 100%.
Excellent. Tom, where do you have the hope, or what do you think we have to focus on to close that gap?
Yeah, I'm gonna go to sort of a concept of the way we think about it. I mean, healthcare is very conservative for good reasons, because we're dealing with life and death and serious, evidence-based, research-based recommendations. But the way we organize ourselves and the way we change, unfortunately, is also a little too conservative, and we've been a bit slow. And what we've seen in this pandemic is innovation at a scale I haven't seen to solve problems and move care forward in ways we've been talking about, but it's actually happening. And one of the big ones is the enabler of virtual care, which has been around in different forms, but we really haven't embraced it like this. And to the credit of governments in Ontario, they covered the physician fees for virtual care, which weren't covered before. They just stepped up, and that enabled care to continue. So when you see changes happen, which can happen, and we have very smart people in the system, but it wasn't happening. So maybe this is the US style innovation mindset, if I can just stereotype, in the Canadian wonderful compromise informed, brilliant healthcare system coming together. And I think if we keep using virtual care as just one piece of that mindset can continue to propel us forward.
Great. So that's a good positive note. Karen, can you come up with something positive about closing the gap?
Yeah, sure. So I think it's about a broad spectrum of healthcare. I don't think it's trying to compartmentalize. I think it's about personalized, coordinated care and deliver it and how people want to receive it. And I think it's ensure we're optimizing care for the right issue, and we're utilizing, this is really important, public system, and where we can't, private system. The employers are the largest payers of healthcare. Let's make sure they get some relief by using the public system where we can, and using the private system where we have to, because there isn't any public resources. And that will lift some of the wait times for those in the public system who need access, and we're taking it and coordinating it through the employers. So I think it does lift a little bit of the pressure off the public system.
And Sim, I'll give you the final word on closing the gap.
So I think we need to remember that we can't leave anyone behind. So we have to make sure that the people that are most vulnerable are the ones that we focus on with regards to providing them with the technology, providing them the support to help them adopt this. And then also having a mosaic model in which it's not just virtual care, but we also have other options for people to have. And this does have to come from their trusted individuals, whether it be their counselor, their family physician, someone that they trust in, because that will empower them. And knowledge empowers people in order to have change.
I think no one left behind is a good message I've heard somewhere before, but it applies well to this topic. So I want to unfortunately have to wrap it up there. I think we could go on for a little while longer with this interesting conversation, but on behalf of the Globe and Mail, I want to say thank you to our excellent panelists, Karen Adams, Thomas Unger, Simmerpreet Santawalia, and Jace Watford. Thank you very much for being there today, for your insight, for sharing. Of course, thank you to the audience. We had a terrific audience. Unfortunately, we were sold out. Some people had to be turned away, but come to the next one. We have another event coming up on June 16th in this series on virtual care. And in that one, we'll be looking at how virtual care can help individuals with chronic illnesses. Of course, I'd be remiss if I didn't thank our sponsor, CloudMD. Karen is from CloudMD. Thank you very much for making this possible today. All the participants online will get a link to the webcast recording. It takes us a couple of weeks to clean it up and send it to you. Take out all the dirty words I might have said in passing, things like that. But we will send you a link. And in that link, we're going to include links to the programs that Sim mentioned, so you can help them out with donations if you so wish. So again, thank you for being there. Please get vaccinated. That's our best shot, I think, Sim, and stay safe. So thank you and have a good day.
Thank you.